afternoon, Kate.
So what have we got today for you? We have a session on infection control in ambulance. Let's go to the title slide. Well named, an infection control reflective presentation by two people who really like to wash their hands. Thanks for that, Tanya. Introducing myself, Kate Hipsley. I work at New South Wales Ambulance. Tanya Samani also works at New South Wales Ambulance. But if I just go to the next slide, you can actually see our bios there. So I'll just start briefly. So I a registered nurse. I started off working in paediatrics. I've worked in intensive care, day surgery, then got into infection control in a hospital setting, and since 2002 have worked with New South Wales Ambulance. And since that time, implemented infection control and vaccination screening programs. So you can read the rest there. However, probably in view of COVID, just like to say that, we have had multiple outbreaks of infectious diseases that have impacted onto ambulance services. And back in 2002-03, when SARS came along, the ambulance service I worked at had no face masks in their ambulance at that time. So times have changed, things have improved, but we can also always learn, and that's what we're about today. Tanya, over to you.
Thank you, Kate. Thank you very much, Kate. As Kate said, I'm a registered paramedic. I've been in the out-of-hospital profession for about 12 years, primarily working with New South Wales Ambulance. I've been fortunate enough to have a variety of different roles in the organisation, and I've worked both regional and metro, so I do understand the challenges facing out-of-hospital care and infection control for varying demographics and areas. A couple of years ago, I realised I'm really interested and passionate about infection control, so I decided to pursue that a little bit. And I completed a graduate certificate in clinical redesign with a colleague, and the focus on that was environmental cleaning of ambulances in the out-of-hospital setting. I'm also a professional member of the Paramedicine Council and a gold standard hand hygiene auditor. I'm still actively involved in the infection control space, and Kate and I have worked closely together and continue to work together, particularly as COVID unveils greater challenges for us. That's all from me. Thanks, Kate.
Okay, let's move on now. Hospital out-of-hospital infection control. There's some numbers up there on your screen. These are all taken from the Clinical Excellence Commission, which is the is tasked by New South Wales Health to provide infection control advice. And so, yes, these are hospital-based statistics. So that's the scope of the problem in hospitals. And you'll probably be sitting there saying, well, what's that got to do with paramedics? And my gentle hint to you all is that it's everything. So, Tanya, I think this is over to you.
Yeah, so what does all this mean for the paramedic profession? On the previous slide, I hope you all took note of that number. Healthcare-associated infections account for about 200,000. We have about 200,000 healthcare-associated infections in Australia. As we know in our profession, we are the conduit between the community and healthcare facilities and healthcare agencies. So what we do in the out-of-hospital setting, we have a really, tremendous opportunity to start breaking the chain of infection and start having that discussion about what it means. We do have a responsibility to make sure our hands are clean, our vehicles are clean, and we are reflecting the standards of what's coming out of, latest infection control practice. We also know that what we're learning, it does impact how paramedics view infection control. As a registered operational paramedic, I know that a lot of us are just, I suppose, naturally drawn to like a cardiac, program or a stroke program. Infection control, as a group of professionals, we need to start making this a bit more engaging and fun for staff, because it's really an opportunity that has a lot of room for improvement. What we wanted, the research and the focus on infection control can also inform educational frameworks and understand what is really going to give us our biggest bang for buck in out-of-hospital care. There's also at the moment an opportunity to create a body of knowledge and really get into that academic research to create, as a group of professionals, industry accepted standards. Next slide. Okay. So what are the main challenges facing paramedicine and infection control? In the research and everything we've looked at in the past few years, it's becoming very apparent that a lot of our policies are hospital-centric. As we know, we're not four walls of a hospital. Our facilities move. We don't always have access to running water. We have uncontrolled and unpredictable working environments. These are things we all know, but some of the policies are very hospital-centric. So it's just about starting that broader industry discourse about what's actually realistic for us and what's achievable. The picture on your screen, we can see that paramedics are restocking an intubation kit after a cardiac arrest. This picture to me spoke volumes when I first saw it, because I thought if we walked into a hospital and saw an anaesthetist with their airway equipment on the floor of a hospital, we'd all be shocked. But this is just what we have to do to make sure that, we're ready to respond to the next patient. We all do our best. There's no doubt about that. We just are facing, we just need a little bit more attention and focus on policies to make them adaptable for us. Extending on from that last point, I think it's widely accepted that at times paramedicine is poorly understood in the broader healthcare establishment. Are we an acute care setting or are we a patient transport service? These two naming conventions were outlined in the document there that you can see on your screen, the infection prevention application of PPE during COVID. Last time I checked, I don't actually know if we've received any clarity on that. Kate, you might be able to shed some light. Do you know if we've received anything?
I would just say that we're an acute care setting. We're equivalent to what goes on in an emergency department inside the back of an ambulance.
Yep, thank you, Kate. And as a registered profession, we are still, paramedicine is still in its infancy. There's so much opportunity to really grow our profession and development. The community expectation is we need to be adhering to gold standards where we can and striving for what is best practice for us and our patients.
Now, this isn't an infection control lesson for everybody out there, because I'm sure everybody is quite well educated in infection control, but it's just a bit of an overview of what infection control consists of, and we're only going to take us a couple of those components to look at and just have a little bit more of a look at what the evidence is around them, but also how we're applying them with COVID as well. So just a brief overview that what does infection control consist of? It's a two-tiered system. Standard precautions for every patient, and then there's a list of hand hygiene, PPE, etc., etc. Of those, hand hygiene is the most important, but PPE is fast surpassing that in people's minds at the moment. Also, in addition to that, transmission-based precautions for specific conditions. So this is a two-tier system that we've always had since, let me think, I've been around a while, so I'm thinking around about 1990 onwards. This is the system that we've been using. And with all the new diseases that have come along since, the SARS, the MERS, the avian influenza, the Ebola, you basically can pretty well slot them into this system and the system still works. So it's not a bad system. So let's just focus on a couple of those today. But as I said, what do we actually know about how well ambulance services do these activities? And I'd probably just like to put in a little bit of a plug for education here, because we spend a lot of time teaching at induction, and universities would teach about infection control and they would teach all these things. But what happens is in an ambulance setting, it's quite a semi-autonomous workforce, and you run the risk of that information being diluted and changed. And anybody that's ever listened to me teach in an induction course will know the game of Chinese whispers and how the message can be changed over time about what should be done in an ambulance setting. We run the risk of teaching people and then they go out on road and then they go, I'm just going to do what that person does there. and follow along what they do. And so the practice can become diluted or changed over time. We can't see everybody, we can't audit everybody. Well, unlike in a hospital setting where an infection control person, auditor can walk around from place to place and very readily and easily see people doing what they do. So moving on the little spot. Thank you for this gorgeous slide, Tanya. Love it. Hand hygiene. Hand hygiene is what we're going to focus on first. And again, if anybody's ever listened to me teach, it's always the first part of the topic. Now, Tanya is, as she said, an accredited gold standard hand hygiene auditor, and I praise her up for doing that. That's fantastic. So, Tanya, I think over to you.
Okay, thanks, Kate. So, just a bit of a brief, overview as to why, we go on about wash your hands, wash your hands, wash your hands. But I just really wanted to focus on exactly why it is so important to wash your hands, particularly in the era that we're in with COVID being so prevalent in the community and in some healthcare facilities. So soap is, hand washing is just one of the most easiest ways you can really improve your infection control practice in your healthcare establishments or agencies, or even just as an individual practitioner. It doesn't cost much. It's not a complex skill, but I think it's just not, it doesn't have that big bang that trauma and cardiac and stroke projects have. So if we understand a bit more about it, hopefully we'll get a bit more uptake. But soap is constructed of these tiny pin-shaped molecules, and the pin-shaped head of the molecule is hydrophilic. So it loves water, and the tail end is hydrophobic. The coronavirus, the outside of it, is coated with all these dense lipids and proteins. And then so when you have soap and water and you wash your hands, the water-loving end, forms an outer circle, and the formation acts to dissolve these lipids and proteins, and the actions help prevent the virus from entering the cells on the skin. But there aren't many hand washing basins in ambulance with running water, unfortunately. So we do encourage alcohol-based hand rub. It's a no-brainer. It's really easy to implement. But we know from contemporary research and some really interesting studies that have been conducted in the past few years that paramedics do have an over-reliance on gloves. A really interesting international study, including Australia, hypothesised that this was because as paramedics, there's an element of protecting the self. We know that gloves don't always protect the patient or even the paramedic. We know that after we doff gloves, we do have to hand hygiene. So there is a bit of work to be done in this space. And we just want, just clean and safe hands. And I find it interesting, in paramedicine, we often talk about, how safe something is. Like, is that piece of equipment safe? Is that stretcher safe? We need to start having that discourse. Well, are your hands safe? We know that likely the most contaminated surface in the back of an ambulance is the healthcare worker's hands. And so if your hands are not safe, then we really need to get right back to basics, and it's so easily achievable.
Tanya, can I just add in that paramedics and what they were known as before, ambulance officers, were the pioneers of hand hygiene gels and rubs in some ways, because there was no hand basins. And so, in fact, that actually led to them having to use hand hygiene products on road when it wasn't seen favourably in hospitals necessarily. And so in some ways we've been, ambulance has been the pioneers in this. And moving on for you, there you go.
Thank you. And that's really interesting, Kate, just to understand the history of it, and that might understand some of the mentality and how hand hygiene is viewed amongst paramedics. So we do know from contemporary research that there isn't great compliance with hand hygiene practice, as I'd mentioned. Anecdotally and observational studies in Australia validate this. And in a recent study, there was only 2% compliance prior to clean/aseptic procedures with a continuation of paramedics wearing gloves. There's things that we do really, really well and we're so good at, and this is one area where we've just got so much opportunity for improvement. We've got opportunities for change agents, we've got opportunities for academic research, and so this is the time we all need to really, be the leaders in this field. As I said, it's not a complex skill. It doesn't cost very much. We all just need to lead by example.
So hand hygiene compliance was greatest after touching the patient, moment 5. And so I did contact the Clinical Excellence Commission just in the last week and asked for the most recent hand hygiene data for New South Wales. Now, this is not necessarily New South Wales ambulance specific. It's New South Wales ambulance category specific. So this could be patient transport, or it could be, and that includes the local internal ambulance transports within the local health districts. But it was 65.6% compliance with a rather long confidence interval. So the numbers aren't large. We aren't getting a lot of moments observed by hospital-based auditors, which is probably common sense. But we know from our own internal work that moment 2, do I need to go through the moments just briefly? Moment 1, before you touch a patient. Moment 2, before you do an aseptic or a clean procedure. Moment 3, after you've potentially come into contact with someone's blood or body fluids. Moment 4, after you have had contact with the patient, completed contact. And moment 5 is after you have left the patient environment, not touched anything in the environment. So you're talking about maybe you pull the curtains back and then you move away. Time to clean your hands again for moment 5. So we will, as we get more numbers, we get more bang for buck, we will actually be able to see more information to drill down and work out what and why we do it. But we know, for example, that the after moments are so much greater than the before moments. I'm not saying stop any of those after moments. I have always been saying don't forget to protect the patient as well as yourself. So it's a fairly normal self-protective behaviour, but I think we're thinking that gloves protect the patient and they don't particularly protect the patient. So as I said, compliance greatest after touching the patient in that particular study. What are the barriers? Is it I haven't got time? Is there this? We've had lots of KPIs in ambulance around getting to the patient, turnaround times, time on scene. All those sort of things are important, but are they more important than ensuring asepsis in an intravenous cannula, for example? So it's the barriers. What are they? What are the actual barriers? And there are some exceptions for hand hygiene when the care is required so urgently that the patient's condition would be affected by it. But when I ask paramedics and I say how many, what percentage of cases would it be where if I stopped to clean my hands and change gloves before intravenous cannulation, how many, what would be the percentage where you couldn't do that? And it's always been less than 5% in those answers. So let's focus on the 95% where we can do things. So yes, definitely room for improvement. I'll just get off my soapbox now and move on to the next one. So environmental cleaning. Brace yourselves. Cleaning is coming of various types. Tanya, I love that slide. I can find good slides too. There we go. Your turn.
Okay, so environmental cleaning, that's the term used obviously to clean your environment, and for the purpose of this this presentation, it refers really to the interior of the ambulance. We're not really talking about outside of the vehicle. So in 2018, myself and Kate and a few other of our colleagues partnered with a university. We just wanted to understand really what's the bioburden on a surface, and the bioburden is just pathogens that are on a surface. As we know, there's germs and bugs and viruses all around us all the time, but we wanted to understand where these surfaces had the highest amount of bioburden, and does that influence what the route of transmission might be. For some of you who might be aware, the Make Ready model, I'm not going to go too much into it, but just so you can understand what this research is about, is a dedicated cleaning service that's based in the Superstation network here in New South Wales, and an external provider actually comes in and cleans our ambulances in a scheduled and routine manner. So it's not paramedics, they're actually trained, the staff who do a tremendous job are actually trained in cleaning. And then we just wanted to understand, well, what does the bioburden look like in these vehicles that are getting cleaned frequently, and not by paramedics that are in a rush and 2 hours overtime and that are tired or whatever, versus the vehicles that are cleaned by ambulances. For those who might be interested, how bioburden is measured, the index of measurement is a relative light unit. And so you swab a surface, it just looks like a giant cotton bud, a 10 by 10 surface area, and the machine picks up bioluminescence or anything that has adenosine triphosphate activity or ATP activity. They're also called swabs or swab testing. In various literature, you might hear different references to this. So the four methods of auditing that are recommended, you can see on the screen: visual ATP, which is the swabs that I just explained, fluorescent gel and agar testing, that's the Petri dish testing. For the trial, we utilised ATP testing, but visual auditing is also a really good way if you're looking to do any localised projects or just trying to have that first step in understanding where to go. Visual auditing is really good because, again, it doesn't cost any money, and you can just really start to understand. And there's a great template on the Clinical Excellence Commission website. So I encourage you all to go and have a look at that and download it if you need a bit of a first step. So this research, we'll go on to the next.
Can I just drop in there for a second, Tanya? Sorry. So just with that methods of testing, just for anybody looking at doing something, there's a bit of a hierarchy there. So visual auditing is you looking at something and going yes or no. And so it does have a subjective measurement to it. The fluorescent gel, just making sure everybody knows what that would mean. So it's like a stamp, a dot of something which would glow under an ultraviolet light. And so what people do is they stamp various surfaces within, say, the ambulance, so that the person cleaning it doesn't see them doing it. Then they allow the person to clean it. Then they would re-enter the ambulance, and then they would look with the UV light to see whether all the surfaces had been cleaned or not. And so that can become, I suppose, a little bit in a hospital setting, I think it can be gamed because people know where the dot is going to be if they know their manager does everything the same way every time. The agar testing is just basically what you would do if you're having a throat swab, not a viral one, a micro one, and you swab the agar, you put it in the hot box, allow it to grow, and what grows. Well, the thing is that we're not living in a sterile environment, and so lots of things will grow, but you would need microbiologist advice to actually determine what's actually pathogenic. You swab my hands, you'll grow some organisms. How many of those are pathogenic and how many of those are my normal flora and should be there? So ATP was probably considered the best way of being able to determine the level of bioburden without needing to know the specifics of it. Have we reduced it from there to there? And that's what we're trying to do, is always reduce and minimise the risk by that. Sorry, Anya, I'll let you go on now.
No, that's definitely great context. So just before we continue, I just noticed there's a couple of questions that come in. So we're going to save all the questions to the end, but absolutely, if you have any questions you want to send through now, that's fine. But just so you know, we're not ignoring you. We're just going to save them to the end. So this research that we conducted was, I thought it was quite interesting. If anyone out there is like me and not a statistician, then you might be, forgiven for getting a bit frightened by this slide. So you don't need to get into the nuts and bolts of it. But the 2 points at the bottom is really probably going to summarise it. So there wasn't actually a huge statistical difference in the bioburden accumulation across 6 of the high-touch surface areas that we tested. And the areas that we tested are on the left-hand side there. So the crash drawer, that's the top of the drawer when you first walk into most ambulances. The BP cuff, the mobile data terminal, cardiac monitor, and that was primarily the handle, and the stretcher handles and the steering wheel. So statistically, there wasn't a huge difference in the relative light units between them, except for the steering wheel. So, we obviously know that the steering wheel, it's a high touch surface area. Going in and out, the driver might touch the patient, and then, it's a surface of the patient care journey that you just can't avoid not touching. But it also feeds into what we were saying before with the gloves, the over-reliance on gloves. We've all seen it in the news grabs at night, the paramedics driving along with their gloves on. That was particularly interesting. So we'll go to the next slide. And what I also want to mention in the previous slide, the p-value is quite narrow. So that really tells us that the reliability is quite high. So we could conduct this test 100 times over and still get the same result. So the conclusion was that when compared to the standard cleaning model, which is just an ad hoc approach, the Make Ready model cleaning model was associated with a adjusted decrease in overall bioburden. So if you were to add up all those surface areas, of 38%. So this blew me away. I mean, we get excited when there's like a 2% increase in out-of-hospital cardiac arrest and trauma survival rates. So for me, seeing this 38%, it's huge. It's really, it says a lot that with routine and frequent cleaning with the right product, that you can actually get that reduction in bioburden. So that was really exciting.
So when New South Wales Ambulance actually started, I shouldn't be mentioning them so much, but we know where it occurred. When they did do this change, I couldn't believe my eyes that we were going to have professional cleaners cleaning ambulances, not tired, hungry, angry paramedics. So I was really ecstatic about that. But we also needed to make sure that built into it was some measures to make sure we weren't wasting public money as well. And I think you can see from those results that we're not. And so that's all very well and good for large metro areas that can and do, put this into place. And so, Tanya, what % of New South Wales is covered by a Make Ready station? Or what area of Sydney? It's not even 100% of Sydney. So there's Make Ready stations across New South Wales Ambulance, and we know that they are getting more effective cleaning methods. So what does it mean for the rest of the stations? What does it mean for the regional stations and the remote stations? And this can be the advantages and the improvements that have been made can be refined, can be extrapolated, and can be targeted and tailored to other areas. And so this was, when in a priority setting, we were looking at level 1 to 6. This was number 1, but we were looking at all the other possibilities of how you would adapt, use the processes that you have done to introduce this and to get that level of improvement for that amount of people in metropolitan Sydney, and how do you then target the specific improvements to take place in the rest of the metro area, the regional areas and the remote areas. So we believe that this can be more widely taken up if you specify from your optometrist. We recommend, so I'm not meant to be talking about New South Wales Ambulance, but we recommend medium impact as the appropriate level of protection. There's an Australian standard on that. So the brands differ, it's personal, base shapes are different, and so you just need to kind of make sure that you get to try it on and you get to decide and consult with a professional if it's complex at all. And the recommendations for PPE use in the warmer months, I have definitely supported any staff that wanted to take off their overshirts and just wear their T-shirts. And as soon as possible after removing your PPE, you do don your proper uniform again. I think there's people will have trialled in hospitals. I'm not sure if it's been done in ambulances. Happy to hear from people about putting your names and a sticker or a bit of tape across there. Andy paramedic, Tanya paramedic, whatever, to personalise it. I know in hospitals are actually putting photos of themselves so that their patients know what they actually look like. So that was about recommendations as an anonymous attendee, recommendations for PPE use in the warmer months. People are already sweating heaps now. And Leanne, yes, a suggestion be made here to remove your shirt and only wear an undershirt under PPE overheat. Yes, agree with both of those. Is there any way to clean gloves? Don't clean your gloves, just change your gloves when you need to and clean your hands in between. I think where that question is going, is there any way to clean gloves? The gloves boxes in the ambulance could be contaminated by a coughing patient, for example. Minimise the number of things that are open in the back of an ambulance, but that's a long-term issue. That's a long-term issue of moving your fleet towards being everything as much as possible behind perspex so that you can have what you've got inside the ambulance and then minimise risk ongoing. So gloves are a barrier. If you start cleaning them, you reduce the chemical components the chemical components in there, and you potentially reduce your protection that they are providing for you. So no, I don't recommend to clean gloves virtually at all. Okay. So Hamish, does New South Wales Ambulance provide funding? No, they don't. Where New South Wales Ambulance doesn't, and WorkSafe, I'm trying to think of the technical name, has responded also saying that ambulance services or health services do not need to provide prescription protective eyewear. If you are lucky enough to work for an organisation that provides it, good on you, well done. Richard, I understand that statistically speaking, hand washing is far superior to that of wearing gloves. However, in the pre-hospital setting, wearing gloves is more feasible given its accessibility. That being said, my question is, any tips to circumvent the consequences of PPE fatigue, especially during long scene times? Or is it only option to repetitively switch gloves and relying on a process similar to that? Okay. So hand cleaning is the gold standard, yes. Understanding that the gloves are providing you with protection from various hazards. And there is a requirement, in fact, for you to change gloves at all the times when you should, except if there was a requirement to keep wearing the same gloves because of the clinical safety of the patient, and if they were going to deteriorate if you did something and stopped to change your gloves. So what you can find is if you wear gloves for an entire job, what you've got left inside there is germ soup. Inside you've got, a lot of wetness inside your gloves. I would just urge people, where there is time to do so, where it is safe to do so, remove your gloves when you can, clean your hands. If you use the rubs rather than the gels, you have a less gelatinous sort of feel on your hands. So I don't know if I've got enough time, Georgia, just jump in if I'm taking too long, but just with intravenous cannulation, for example, I recommend that if you've had gloves on, as soon as you know you're going to cannulate, remove gloves, clean your hands, and then start setting out your bluey, all your sterile articles and all those sort of things, and then reapply gloves, which will need to be done for intravenous cannulation to protect the paramedic after you've actually done all those different steps. It gives you time for the hands to become easier to get gloves back on. If the efficacy of gloves is reduced by using hand rub on the outside, it is also reduced by hand rub under the gloves, i.e. on my hands. So if you wear gloves and then you clean the gloves with hand products, hand gel or hand rubs, they are deteriorating the integrity of the gloves so that they won't provide you with the desired amount of protection. So if you needed to clean your gloves, if you felt you needed to clean your gloves, then you actually needed to change your gloves. Now, that's again about workflow and how urgent was that job. And if that's the only thing that you can do to keep a patient safe and keep a patient alive, you go right ahead. I'm not here to reduce the clinical outcomes for any patient. I'm there to improve them, and understanding that the more surfaces you touch with those gloves, the greater the risk when you come to do an invasive procedure for the patient. That's the questions for the moment. Georgia, how's the time? Oh, we're over time.
We've got a couple of questions on the chat. Kate, have you seen those?
Q&A, done that one. Is there more?
Yeah, on the chat. Do you want me to do those ones?
Sorry. OPSM have a reasonable range.
But a bit further up, we've got a question from James. In terms of the environmental cleaning of ambulances, were there particular gaps in cleaning methods used in the at-station group, such as wrong cleaning agents, too rushed, etc.? So, James, in that study, we compared apples with apples, so the same type of cleaning product was used. It was just the one cohort of ambulances had frequent and scheduled cleaning, and the other didn't. The products were the same. We had a statistical adjustment for the variation in workload at some stations, and we had one of the best biostatisticians in the state do all the magic around it to make sure we were comparing apples with apples. The testing was conducted at the same time, so I think it was between 2 and 3 in the morning. We made sure that those variances were kept to a minimum, just so they could really be challenged in a robust method to ensure that we got that really narrow p-value. Message from Andrew, looks like a dedicated team, i.e. Make Ready is benefit. Yep, we're fortunate to have them. Question from Sasha, are ambulance services looking into more disposable patient equipment such as O2 SAT Groves?
Just clean them.
Clean them, that's it. Clean your hands, clean the shared equipment. Jara has said OPSM have a reasonable range. I think that's in reference to the prescription oversteps, maybe?
As a prescription protective. Yep. From Emily, is putting 2 pairs of gloves on a good practice? No, not generally. It would only be required under specific circumstances. If you are wearing 2 sets of gloves, you would still need to remove them before you go near another patient anyway. It's again, if you needed to clean your hands, you needed to clean your hands. However, with that waiver, if you need to save a life, you save a life and do it the best you can. And then there's time later to reduce risk. But if you've got enough of a team there to be able to do things properly, then cleaning your hands is the best possible thing that you can do.
Remember as well that a couple of things. First off, Kate mentioned earlier, and this is really important, we don't work in a sterile environment. We're not theatres. This is about reducing risk, and there's a bit of an element here of clinical judgment. So if somebody needs a life-saving intervention, that obviously takes priority, but it's all about amalgamating it together, reducing risk for the patient, for yourself. So, sometimes it's not always achievable, and as a hand hygiene auditor, I can appreciate that. And as a paramedic, it's just not always attainable, but, we can improve our current practice, and that's really the take-home message in a lot of this.
Question, Samuel, is that the next one?
Yep.
What if a paramedic is experiencing adverse effects due to hand sanitizer? Try different brands. We try and provide a range so that you can try different types. I would seek advice from a doctor about your general health and the issue with the irritation or inflammation, to see if there's a medical condition that needs some support and help. And work with your equipment people or your infection control people to get the best possible product for you. And Jara, it was NIBP, cuffs are a real issue, very hard to